afternoon, everyone. Today's topic of the PG activity is microsatellite instability syndrome. Now, let us first discuss about the gene. Gene is made up of DNA, and a DNA sequence determines the function of the gene. It is transcribed from DNA into RNA, and then it is translated to protein. It is a double helix structure. DNA is a double helix structure, and it is made up of nucleotides A, C, G, and T. It is tightly packed around the histone and formed into chromosome, which is present inside the nucleus. DNA codes for the amino acids to form proteins by transcription and translation. Let us discuss a few terminologies. First is an allele. So an allele is an alternative form of a gene that is located at a specific position on a chromosome. Homozygous, when identical alleles of the gene are present on both the chromosomes, and heterozygous is when two different alleles of the gene are present on both the chromosomes. Now, this here we can see this is an allele 1, this is an allele 2. Now, this is a homozygous condition, this is a heterozygous representation. Now, epigenetics, study of heritable chemical modifications of DNA or chromatin that does not alter the DNA sequence itself. DNA methylation is because of addition of methyl group to DNA base cytosine by enzyme methyltransferase. Now here what we can see is histone acetylation is adding up of the acetyl group to lysine of histone protein, and that is with the help of acetyltransferase. This is a microRNA and this is an mRNA. If there is no translation of this mRNA, there will not be any formation of any protein. Now, what are mutations? They are defined as permanent change in the DNA. They affect the germ cells and transmit it to the progeny, and they give rise to inherited diseases. That arise in somatic cells that causes cancers, and some cause congenital malformations. Now, what are the types of mutations? So first is point mutation, which is within the coding sequence, mutations in the non-coding sequence, deletions and insertions, alterations in protein coding genes, alterations in the non-coding RNAs, and trinucleotide repeat mutations. Now, trinucleotide repeat mutations, they form the basis of microsatellite instability syndrome. Now, point mutations, they cause a single nucleotide base substitution in the genetic material. What is a transition? That is purine by purine, or pyrimidine is replaced by a pyrimidine. Transversion is purine in place of pyrimidine and vice versa. So this is an example which is representing the point mutation where there is a single base substitution. What are frameshift mutations? So these are genetic mutations because of insertions or deletions of a number of nucleotides in a DNA sequence due to triple nature of the gene expression by codons. Insertion and deletion can change the whole reading frame. So here we can see in frameshift mutation, the whole reading frame is getting changed because of insertions and deletions of a number of nucleotides. Now, what is loss of heterozygosity? It is a loss of function of one allele of a gene in which the other allele was already inactivated. So here this is a normal allele, this is a mutated allele, and now there's a loss of function because of the gene which was already inactivated. Now, what is genomic instability? It can be a chromosomal instability or it can be a microsatellite instability. So, chromosomal instability is when karyotype shows abnormal karyotyping in the form of abnormal number of chromosomes. And microsatellite instability can be the type of DNA repeats can be satellite, mini satellite, microsatellite. So satellite where the number of repeated nucleotides are 5 to 200, mini satellite when they are 10 to 60, and microsatellite then when they are 1 to 6. Now, microsatellite specific site is composed of two parts. It has a central core and a peripheral flap. And the specificity of microsatellite is due to the change in number of core repeating units. Number of repeat unit varies from person to person, and they constitute around 3% of the human genome. Amongst them, there are dinucleotide or trinucleotide repeats, but the most common is trinucleotide repeat, that is TAA. Most frequent dinucleotide will be GT followed by an AT. Human genome contains 50,000 to 1 lakh microsatellites, and they are unique and uniform in length in each person. Now, what are the properties of microsatellites? So they are locus specific. It is codominant. What do we mean by codominant? When the contribution of both the alleles are visible in the phenotype. The highly polymorphic, provide variable pattern. and they are PCR based. It can be obtained from small amounts of tissues. Now, microsatellites are classified according to the type of repeat sequence. So there are 4 types: perfect, imperfect, interrupted, and composite. So perfect is, it is not interrupted by any base which is not belonging to the repeat sequence. So this is a perfect repeat sequence. Imperfect is when the pair of bases between the repeated sequence that does not match the repair sequence. Interrupted is there is small sequence within the repeated sequence that does not match the repeat sequence. So here we can see one sequence followed by another different sequence and then followed by the previous sequence. And composite is two adjacent distinctive repeat sequence. So this is one repeat sequence and adjacent to it is another repeat sequence. Now, microsatellite instability. What can happen if there is a microsatellite instability? It is associated with many tumor conditions. Most importantly is colorectal carcinoma, that is hereditary non-polyposis colorectal carcinoma. Second is endometrial carcinoma, then stomach carcinoma, ovarian carcinoma, urinary tract cancer, or small intestine carcinoma. Now, MMR gene mutations, they can be hereditary or sporadic. So, hereditary germline mutation, that is point mutation or frameshift mutation. Sporadic or epigenetic mutation, it can be because of the hypermethylation of cytosine at the CpG region. Now here this diagrammatic representation, it shows us about the MMR proteins. So the very important four MMR proteins are MSH2, MLH1, MSH6 and PMS2. These are the 4 to be remembered in this sequence only because they have this is the order in which they are being affected most to least. Now, MSI and colorectal carcinoma. So there are 2 molecular pathways which are involved in the colorectal carcinomas. So ABC beta catenin pathway, this will lead to adenocarcinoma of the colon. And the microsatellite instability pathway will be related to the microsatellite instability syndrome or the Lynch syndrome. So APC beta catenin 80% sporadic colon tumors include mutation of the APC gene. Microsatellite instability pathway 20% sporadic associated with defects in DNA MMR, and there is accumulation of the mutated microsatellite repeats. Now, pathogenesis, as we have already discussed, that the APC beta catenin is responsible for the classic adenocarcinoma. MSI defects in the DNA mismatch repair and accumulation of mutation in the microsatellite repeat regions. Microsatellite unstable colon carcinoma is another mechanism which mutations in the DNA mismatch repair genes. MLH promoter is hypermethylated in this condition and there is a BRAF mutation. So it is without mutation in the DNA mismatch repair genes. This is because that MLH1 is getting hypermethylated and there is a BRAF mutation. Fourth is increased CpG island methylation in the absence of MSI. So in this CpG island methylation, there is KRAS mutation. Now DNA methyl mismatch repair mechanism. So we are discussing about the second mechanism, DNA methyl mismatch repair mechanism. So the important genes which are responsible are PMS2, MLH1, MSH2, PMS1, MLH3, MSH6. But the 4 most important, MSH2, MLH1, MSH6 and PMS2. Now after replication, see the parent strand is going to be methylated and daughter strand is not methylated. So MMR proteins can actually recognize the parent strand like that. Mute S will identify the mismatch nucleotide error. Now, type 2 TGF beta receptor, if there's a mutation in TGF-br2, so what will happen? There will be proliferation, uncontrolled proliferation. And if there's a loss of BAX, so what is BAX? It's a pro-apoptotic protein. So if there's a loss of BAX, the abnormal genetic clones are going to be very much. So it won't let the apoptosis to happen. Now the microsatellite mutation, since it's a region of repeated sequence of nucleotides, while replication and recombination, they are much prone to mutations. So 2 types of mutation, unequal crossing over and replication slippage. These 2 can be other 2 mechanisms which can cause the microsatellite mutations. So I'll briefly talk about the unequal crossing over. During crossing over, unequal length of each chromosome is exchanged, as we can see. One chromosome is larger, other is smaller. Homozygous chromosome, it receives a smaller number of repeats. Now, replication slippage, what's happening? During DNA replication, polymerase has a tendency, the DNA polymerase has a tendency of slipping. Suppose you're reading a chapter for the 5th time. So you'll tend to skip a few topics because your mind tends to be like, I know this, I know this. So you tend to skip some topics. Same ways, DNA polymerase is continuously acting and acting. But there comes a time when it slips and it misses things out. So that is when the problem arises. But this problem has a solution because now the MMR genes would come into play and they are going to repair this problem which is caused by the slippage of the DNA polymerase. So one DNA strand is temporarily dissociated from the other and it rapidly rebinds in a different position, which will lead to base pairing errors, and it continues the lengthening of the new strand. So there will be increase in number of repeats in the daughter strand and decrease in number of repeats, or you can call as there will be deletion of the repeats from the parent strand. So this is the diagrammatic representation of the methyl mismatch repair. So the three important proteins are MUT-S, MUT-L and MUT-H. See, MUT-S has to recognize the strand, parent strand. Then the MUT-L recognizes the methylated parent strand. MUT-S first comes and attaches. Then MUT-L recognizes the parent strand. Then there happens the cleavage of the error strand. Then helicase will come into play. It will try to stabilize the single strand binding protein. And then there will be removal of the error strand by MUT-H. And then resynthesis will happen with the help of polymerase and the ligase. So they are going to add new base pairs to the removed base pair areas. So important genes, as we have discussed it earlier, after replication, parent strand is methylated and daughter is not. Now, let us talk about the hereditary non-polyposis colorectal cancer or the Lynch syndrome. So endometrial cancer, it has a risk of 20 to 60%. Small intestine cancer, MSH2 and MLH1 are affected. Hepatobiliary and pancreatic cancer, MSH2 and MLH1. Gastric cancer, MSH2 and MLH1. Ovarian non-serous cancer, MSH2, MLH1. And breast cancer, MLH1. Renal pelvis and ureter cancer, MSH2 and 6. Bladder cancer, again MSH2 and 6. So renal, ureter and bladder, MSH2 and 6. Sebaceous gland cancer, Muir syndrome, prostate cancer, MSH2, and central nervous system cancer, that is Turcot syndrome. Now, Lynch syndrome, it's an autosomal dominant condition. Most common in young patients. The clinician is going to suspect Lynch syndrome in a patient who is young. Most common site is right colon. Yes, it can also be present in the left colon, but the most common site is right colon. MSH2 has the maximum risk, followed by MLH1, followed by MSH6, and then PMS2. Colon is the most common site. Most common extracolonic site is endometrium. Now, this is a good concept. You should remember that sebaceous skin tumor plus any internal cancer would be a Muir syndrome. And sebaceous skin tumor plus Lynch syndrome is again Muir syndrome. So what do I mean? That Lynch syndrome can be a Muir syndrome, but every Muir syndrome is not associated with a Lynch syndrome. So better prognosis than sporadic. Inherit one mutant and one normal allele, and it is less likely to have mutations in KRAS and P53 because we already know KRAS mutation is that mechanism, that pathogenesis is involved because of the methylation at the CPG base, right? Now, this is a diagrammatic representation of microsatellite instability, which has been taken from the Robbins. So here we have discussed already the genes, like the MMR genes which are involved. And yeah, so this is another diagrammatic representation telling us about, again, what happens. See, this is Lynch syndrome, colorectal carcinoma. This is sporadic CRC. So this is MMR gene inactivation is happening. Now here what is happening in sporadic CRC, that MLH1 is hypermethylating. In Lynch syndrome, there are germline and epi mutations in the MMR genes. And second hit is going to cause deletions, methylations, and mutations, and then it is going to cause MSI. So frameshift mutations are going to happen once the patient has MSI in genes with coding, right? The microsatellite repeats. So we need to remember what kind of a mutation is happening here. Frameshift mutation, not a point mutation. So KRAS and beta catenin mutation here, and BRAF mutation, as we discussed BRAF. So BRAF mutation is associated with MLH1 hypermethylation, and KRAS and beta catenin are here associated. So this is all going to lead to methylation of the DNA, and it will lead to colorectal carcinoma. Let us discuss the histopathology. Now, what you can see over here is a very classical microscopic view of a Lynch syndrome colon. So here, see, this is a gland. These are what? Retraction artifacts around the T lymphocytes. So these are tumor infiltrating, like the lymphoid cells, right? Now, another presentation, another histopathological picture which you can see in a Lynch syndrome is signet ring cells. So, see, you can see the presence of tumor cells. They have intracytoplasmic mucin filled vacuole, and it is causing lateral compression of the nucleus within extracellular mucin or infiltrating directly in the stroma. Now, mucinous histology, what you can see here, extracellular mucin accumulation. Bounded, it is either by neoplastic epithelium or by the host stroma. Now, this is a medullary carcinoma. Again, you can see it in Lynch syndrome. So, expansile appearance of the advancing tumor margin. See, such an expansile appearing margin, like tumor. Now, it is poorly differentiated, consists of nests and trabeculae, sheets of small to medium-sized tumor cells, scant to abundant eosinophilic cytoplasm, and frequent mitotic figures. A distinct stromal population of small lymphocytes can be seen over here, right? Now, this is a necrotic type. So, necrotic, you can see characteristic necrotic debris which are in the glandular lumina, so called the dirty necrosis. Now, again, let's see the picture first. Now, see, this is a muscularis layer, and these are ill-formed glands which we can see over here. So, this is Crohn-like lymphoid reaction which you can see in Lynch syndrome. So, it is composed of lymphoid follicles of different sizes, right? Serosal, subserosal or precolonic fat, two or more large lymphoid aggregates in a section, and it resembles the Crohn's transmural inflammation. Can you see how ill-formed, ill-defined glands you can see over here? So this is transmural infiltrating lymphocytes. These are all lymphocytes in the presence of small round lymphocytes within the tumor epithelium. Let us talk about the immunohistochemistry. Now, IHC plays a really very important role in diagnosis of this Lynch syndrome. So let us talk about MLH1, MSH2, MSH6, and PMS1. Now see the diagrammatic. See, we have to remember these blue cells, what we are seeing over here, these are actually the tumor cells, and these are the stroma, right? Now you can see that there is brown pigmentation in both of these. You can see the brown pigmentation of the stroma, which says that it is like tumor is not taking up the brown stain over here. So tumor is negative for MSH2 and MLH1, but yes, you can see the stromal brown coloration. Okay. Now, if I talk about MSH6 and PMS2 over here, the tumor itself has taken the brown color. That means it is positive for MSH2 and PMS2. Now, IHC is staining for the mismatch repair proteins. So, these are the various interpretations which we can have while we are looking at an IHC for the various MMR genes. Now, what are the limitations of IHC? It requires well-experienced pathologists. It is difficult in interpretation. Improper patchy staining, it is less sensitive. And defective MMR may still be antigenic. Now, let us talk about the HNPCC testing algorithm. So, see, if there is MSI in the histology, so you can see that the histopathological picture that we discussed, like the signet cell, mucinous, the necrotic, Crohn's, like everything. Second, the Bethesda criteria. So we'll discuss it later. And very important, the clinician's request, if the clinician is suspecting. So now we can say that the microsatellite instability testing is to be done, which is by PCR. We all know that microsatellite has a property that of PCR, right? Mismatch repair protein, IHC also can be applied to it. Now, which protein is lost? Suppose MLH1. If I talk about MLH1, we already know in MLH1 what happens? There is hypermethylation and there is BRAF mutation testing over here. And if the protein is not lost, so likely it is, suppose it is HNP-CC, right? So BRAF mutation, if it is negative, suppose it is negative, so HNP-CC is possible. But if the mutation is positive for BRAF, it is unlikely to be HNP-CC, right? Now, let us talk about the colon adenocarcinoma. It is the most common malignancy in the GI tract. NSAIDs and aspirin have a protective effect. And COX-2 is highly expressed in 90% of colorectal carcinomas and 40 to 90% of adenomas. Now, this is the mechanism, APC beta-catenin pathway, by which the colon adenocarcinoma happens. So, it promotes the degradation of the beta-catenin. 80% of the sporadic carcinomas include the mutation of APC. Loss of APC will lead to accumulation of beta-catenin because it is causing the degradation of beta-catenin. Now, beta-catenin will translocate to nucleus and it will bind to the DNA binding factor. Now, what is the DNA binding factor? It is TCF. Transcription of MYC and cyclin D1 gene will lead to the cell proliferation. So, if MYC and cyclin D1 they transcribe, it will lead to cell proliferation. Along with this, mutation of KRAS promotes the growth and inhibits the cell apoptosis. So, KRAS mutation will promote cell growth, inhibit cell apoptosis. Now, there are two tumor suppressor genes you need to remember, SMAD2 and SMAD4. Now, if they also mutate, it will inhibit the TGF beta signaling, which will lead to unrestricted cell growth. So in short, what's happening? There is unrestricted cell growth because the tumor suppressor genes are now getting mutated. So TGF beta is going to be signaled, and then it will lead to unrestricted cell growth. TP53 mutation also occurs in this. So see, we are talking about the adenocarcinoma of colon. So here KRAS mutation is happening, TP53 mutation is happening, which is missing in the MSI pathway. Now, epigenetic mutations, hypermethylation, it occurs at the CPG areas of tumor suppressor gene. And chromosomal instability is a hallmark of APC beta-catenin pathway. This is the diagrammatic representation of all what we talked about. So APC beta-catenin, KRAS mutation is happening, TP53 at 17p13 and LOH and 18q21. So these genes are actually needed to be remembered and revised. Now, let us talk about the MSI testing. So there are two ways. There are two criteria. So the first is Amsterdam criteria and the other is Bethesda criteria. Now the Amsterdam criteria says that at least 3 relatives with CRC, colorectal carcinoma, one must be a first degree relative of the other two, or a Lynch syndrome associated cancer. See, it can be anything. It can be an ovarian cancer, endometrial cancer, or a CNS tumor, right? CRC involving at least 2 successive generations, 1 or more cancer cases before the age of 50 years, familial adenomatous polyposis should be excluded, and tumors should be verified by histological examination. Now, what is the Bethesda criteria? It says that a colorectal cancer is diagnosed in an individual who is less than 50 years. There are multiple synchronous, metachronous, Lynch syndrome associated tumors regardless of the age. Colorectal cancer with MSI, so high histology diagnosed in a patient who is younger than 60 years. Now, colorectal cancer is diagnosed in 1 or more than first degree relative with a Lynch syndrome related tumor, with one of the cancers being diagnosed in less than 50 years, right? Now, invasive carcinoma with MSI have prominent mucinous differentiation and peritumoral lymphocytic infiltrate. Now, MSI can be identified by absence of IHC staining for MMR proteins and molecular genetic analysis of microsatellite sequence. Now, MSI analysis, see, we can isolate the DNA. So, the genomic DNA of a normal and tumor tissue isolated from the paraffin embedded material by taking tissue punches from the tumor and the normal areas, and then they're stained with HNE. Now see, you take tissue fragments, you apply proteinase K-Chelex resin. Now you add 100 to 200 microliters of lysis buffer. You'll put it for overnight incubation at 56 degrees centigrade. Now the dissolved DNA is separated from the cell debris by centrifugation for 10 minutes. DNA containing supranatant is separated from this calyx resin and it is transferred to another tube. Multiplex fluorescent PCR is done to identify the MSI. Markers will be labeled with the fluorescent dyes over here. PCR products are passed through the gel electrophoresis and tumor gene length is compared with the normal gene and interpretation is done. Tumors were classified as tumors with instability more than 30% of the markers, which is more than one marker, MSI-H. Tumors with instability for less than 30% of the markers, which says only one marker, that is MSI-L, and tumors with no instability. Now, tests for MSI can be useful prognostic tool. They can be a useful prognostic tool. So, they have better overall survival rate, responsive to chemotherapy like 5-fluorouracil than tumors without MSI. These are my references.